After a couple of technical difficulties with the firewall here at Christiana Care, I can now show you that in fact there is a DelawareMinimed.org site. And you'll notice here that for the different sessions, there was the opioid session, there's the presentation in PDF format. There was the cardiac rehab from last week. Somebody requested some additional information, so we've got that posted. Probably tomorrow, if not over the weekend, this evening's presentation will be posted online in PDF format. Just need Acrobat Reader for that. So this evening we're going to talk about epilepsy, and we've got Dr. John R. Pollard. He's a neurologist with Christiana Care Health System. He joined Christiana Care from the University of Pennsylvania, most recently as an associate professor of clinical neurology at the School of Medicine, director of clinical neurophysiology fellowship at the Hospital of the University of Pennsylvania, and associate director of the Penn Epilepsy Center. He is board certified in neurology by the Board of Psychiatry and Neurology, with added qualifications in neurophysiology, and by the American Board of Clinical Neurophysiology, with added competence in epilepsy monitoring. He earned his medical degree from the University of Pennsylvania School of Medicine and completed his residency in neurology and fellowship in epilepsy at the Hospital of the University of Pennsylvania. Dr. Pollard, oh, there you are. Thank you very much.
Hi, thank you very much for having me. I appreciate the opportunity. You're always supposed to start out with a joke, but I have a 7-year-old, and so all that comes to mind is a knock-knock joke. So let's see. So knock knock. Interrupting cow. Moo. So. So actually, we're supposed to save all the. Okay. So actually, we're supposed to save all the questions until the end. That's sort of a reminder, also. I'm sort of used to calling on people who are getting questions during talks, so I'll do my best not to answer you. How about that? Let's see if you can bring this up. So today we're going to talk about epilepsy and the latest advances in treatment and care. Just some disclosures. I'm a very small part of a biomarker company in epilepsy. We're not going to be talking about that information today. And then some research grants that I've participated in recently. In terms of educational objectives, we're actually going to be talking about epilepsy centers and identifying standard treatments for epilepsy. And then we're going to highlight recent advances in treatment of epilepsy. So, see how the videos go. This woman is in an epilepsy monitoring unit. All right. So, so that was an epileptic seizure. And I guess the first thing I wanted to point out is that it's a pretty horrible thing to experience. And I just wanted to talk a little bit about what an actual seizure is, and then sort of how we work that up, and what is seizure versus epilepsy. So that seizure, what happened to her is that there was an electrical disturbance in her brain, and that essentially is a hypersynchronous electrical activity. So the brain is a massive multiprocessor. If the brain is doing the same thing, if the entire brain is doing the same thing at the same time, that is terrible dysfunction. That's exactly what happened to this woman. It is actually a symptom. We consider it a symptom of brain dysfunction. It's not a disease of itself. And the seizure itself, that electrical activity, can be associated with involuntary stereotypes, so it's the same every single time symptoms. If we were going to work this up, actually we have pretty limited ability to work this up. It turns out most of what we use is an MRI scan of the brain and electroencephalograms. An MRI scan of the brain might show something like this. Just to orient you here, this is as if the front of the face were just sort of taken off of a patient. And you can see here is where the left ear would be, and here's where the right ear would be, and the top of the head and the bottom. And there's an area here called the hippocampus. And you can see a little bit of the seahorse. I don't know if the projection is. The projection is not good enough for it. There's a little bit of a hippocampus there. You can see the other side is sclerosed, and you can't see that internal architecture there. But that doesn't tell us what happened at that time, right? That was just, this is a structural image. In fact, if she was having that event at the time, the MRI would be completely blurry. So what is it that we actually use to define the seizure when it's happening? We use something called an electroencephalogram, which is a 100-year-old technology. It does record brain electrical activity. So there are literally electrodes that are on the scalp. And we use that to determine, in between seizures or during seizures, we use that to determine whether a seizure is likely to start in one spot in the brain or whether it's likely to start over the whole brain. And we can tell if someone is sort of awake or asleep. And we can tell if someone is having a seizure or not. The electroencephalogram, if you were to look at the top of someone's head, you can see where these electrodes are placed. The even numbers are on the right, the odd numbers are on the left, and they're roughly the F is frontal, T is temporal, O is occipital, so they roughly correspond to the kind of areas of the brain over which the electrodes are located. If you look at a normal electroencephalogram, the EEG leads are actually compared to each other. So there's so much artifact or so much extraneous signal that's not coming from the brain. This signal that's coming from, electrical signal coming from the muscle, coming from your eyes, coming from your mouth, that actually you have to compare one electrode directly to an electrode very close to it in order to filter out a lot of that normal signal, but signal that's not brain. And so we'll actually subtract. So if we want to look at F7, we'll subtract FP1 from F7 and then F7 from T3. And then we look at this longitudinally and time. So each one of these is a second. The first rhythm that was ever found by Hans Berger was something he called alpha rhythm because it was the first one. And it's mostly towards the back of the head. And you can sort of see a sinusoidal pattern here. That's a normal brain activity. So what happens when it's not normal? You have the same sort of setup here, where longitudinally you'll see the time go, and then here over the left temporal region you actually start to see some rhythmic activity, and that's that hypersynchrony that I was talking about. And here in the left temporal lobe, you start to see sharp waves, or we call it spike and wave discharges here over the left temporal region, and that's the beginning of a seizure that woman had that we just saw. There are other findings you can see on EEG. This is a different kind of finding. Epilepsy is pretty common, so you might have heard of children having something called absence seizures. And this is sort of a classic image of 3 hertz spike and wave discharges that you would see starting basically over the whole brain all at once. So you have the normal EEG we were looking at before, and then spike and wave discharges you can see pretty much throughout the whole brain. So then we're talking about seizures. We have some biomarkers of seizures, like MRI can kind of see the abnormalities, and EEG you can see how the seizure is happening in real time. But that's seizures. So what then is epilepsy, and why do we talk more about epilepsy? Epilepsy is actually an enduring predisposition to have a seizure. So if you're essentially more likely than your peers to have a seizure, you have epilepsy. We have some rules about this. You have to have had at least one epileptic seizure in your lifetime. You can't just have a bad EEG, for example. You have to have 2 or more unprovoked seizures, or 1 seizure, and then certainly more than a 60% chance of having a relapse over the next 2 years if you were to have epilepsy. Or you can have something called an epilepsy syndrome. So remember I said it was a symptom. Seizures are a symptom, right? Well, if when the main symptom does turn out to be seizures, we have some syndromes that have been described, that I have described, that previous people have described. One of the main ones, so in adults, one of the main ones turns out to be juvenile myoclonic epilepsy. So this is a good example of an epilepsy syndrome. This was actually comprises about, it's kind of a complicated name for this, but it comprises about 10% of all epilepsy in adults. We call it an idiopathic generalized epilepsy. In other words, the EEG looks more like this. It starts over the whole brain all at once. The seizures start over the whole brain all at once. People can have myoclonic jerks. That's like a jerk of an arm or leg or head, usually in the morning. Someone might fling their toothbrush across the room, for example. People can have generalized tonic-clonic seizures like the one that we saw before. And people can have absence seizures, which is quiet stare, maybe last 5 to 10 to 15 seconds, maybe a little bit of chewing. And their examination is usually pretty normal. So basically in between seizures, these are normal average people, and then when a seizure happens, that occurs. Unfortunately, for these people, the prognosis is pretty poor off of medications. It usually does not remit off of medications. If you were to look at an EEG of a patient with juvenile myoclonic epilepsy, this would be a good example. It's not as pretty as a 3 hertz spike and wave, but this is sort of a spike and wave discharge that might happen 3 to 4 times per second. Epilepsy is actually pretty prevalent when you get down to it. Who is it who actually gets this? And I would say that the incidence, I would point out, the incidence actually slowly increases with age. You know, there is a peak at age less than 10, but actually over age 60, there's a big increase. And so 50% of all epilepsy is going to be in people over the age of 60 fairly soon. One thing to point out is that while this is a disease that affects all age groups, the biomarkers that we have actually are not as good in people over the age of 60. So the EEG that I showed you before, the sensitivity of the EEG, the percentage chance that you're going to detect an abnormality, is very high when the age less than 10, and it progressively decreases. So in someone who's over the age of 70, the sensitivity is only about 26%. At the same time, on MRI scans, we accumulate some wear on the tires as we get older. And the MRI scans often show abnormalities that do not actually cause seizures, so the MRI is not as useful either. So that's sort of an age epidemiology explanation of who gets epilepsy. If you think about this, the population as a whole, it does turn out that something like 7% of us will actually experience a single seizure. 3% of the population will actually experience recurrent unprovoked seizures, so that's epilepsy. And then 1% will actually have drug-resistant epilepsy, so people are taking medications and the seizures are still happening. What are the consequences? To me, that looks pretty horrendous, and I've seen it over and over again for 15 years at this point. And it, people are pretty scared about having these things, and it does turn out that they are pretty morbid. So, at worst, epilepsy can have a mortality rate of about 2 to 2.5% per year. There are also some neuropsychiatric complications and also social disability that comes from having these seizures. So if we look just at the mortality, it turns out that the seizures themselves do cause mortality from driving accidents, from suicide, from drowning, or from just from falls. And there's also something called sudden unexplained or unexpected death in epilepsy patients. And this is essentially people who just don't wake up in the morning. And of course, and most of you have probably heard of John Travolta's son actually died of this. SUDEP, or sudden unexplained death in epilepsy patients, even though you may have just heard that term for the first time, actually turns out to be the #1 cause of mortality in people with seizures. So the big question then is, why is epilepsy being presented here now, right? You just heard about the opioid crisis, which kills 65,000 people a year. You've heard about cardiology problems last week that leads to high mortality. Well, it does turn out that for seizures, the mortality rate in the U.S. is actually 45,000 deaths per year in the U.S. due to seizures. So it's actually about the same as breast cancer. It's about the same as all the deaths from traffic accidents. And what about just average accidents if you're not actually driving? If you're not going to die, what is the morbidity of having epilepsy? In the UK, 29% of epilepsy patients were actually reported to have an injury from seizure in the previous year. If you just look at a population that's going to the emergency room, 5% annual chance of an ER visit. In nursing homes, actually, where there's a very high incidence of seizures, there's a 1.2% chance of injury annually. And these are the people that are getting the very best care, right? Supervised care. When you actually ask patients who suffer from epilepsy, what is the biggest problem? They actually don't say the injuries, and they don't say, I'm worried about dying. What they say is, I can't drive, which is a terrible disability, really. I think 70% of people rank that as their #1 concern. And people who have epileptic seizures in which you lose awareness are not allowed to drive in the state of Delaware. There's a mandatory reporting. There's a series of other things that people complain about as well: lack of independence, trouble with work and education. I have to say that seizures are covered under the Americans with Disabilities Act, but I very rarely see a patient who had a seizure at work who didn't get fired on some sort of pretext. Not because they had a seizure, but they'll make up something. The social embarrassment, people worry about being dependent on medications. There's also mood problems we'll touch on later, and of course the safety issues we discussed. One of the main issues that I actually find when I'm talking to epilepsy patients is that we actually have pretty unclear information about what's actually happening to them. So the main question is, like, if someone comes to see me in the office, and I'll say, did you have any seizures, right? And I'm thinking to myself, let's see, are those events seizures? So I want to ask some questions about that. How severe were the seizures? And were you adherent to the medications that I was giving you at the time and around the time of those seizures? Well, it turns out that the disease itself causes some trouble with memory, so it's something called accelerated forgetting, in which epilepsy patients over the course of a day literally will forget what happened to them during that day, even though they can learn something just as well as anyone else at the time when they're trying to learn it. And also, when I'm asking about the seizures, they might say they're aware of all their seizures and tell me about them, but it turns out maybe not. So this is a classic study in which patients were admitted to an epilepsy monitoring unit, like that one that we saw that patient in. 31 subjects were admitted, all who had spells of loss of awareness, and all claimed to know when the seizures occurred, at least sometimes. They knew. And then the patients were asked when they were having seizures in the epilepsy monitoring unit if they had a seizure. And at random times they were actually just asked even if they didn't have a seizure, just sort of for internal consistency. And the results were that there were no false positives. In other words, if you asked someone did they have a seizure, if they didn't have a seizure, they didn't have a seizure. They were correct. But 30% of patients actually denied that they had any seizures at all, even though seizures were definitely recorded during these admissions. And only 23% were aware of all the seizures that they had. So unrecognized seizures are actually incredibly frequent with patients also. So not only is there a problem with memory, but actually even when the seizures happen, the patients might actually not even know that they happened, and that's incredibly frequent. When you have this kind of problem, you end up having an information problem because there are so many specialists that are involved in your care also. So how do we interchange all that information? How do we bring that together? Because when you arrive at a place that doesn't have an epilepsy center, you do have some seizure specialists like me. I call myself an epileptologist because I have a board. But neurosurgeons, neuroradiologists, neuropsychologists, clinical psychologists, psychiatrists, nurse specialists, EEG technologists, social workers, the Epilepsy Foundation, which is an amazing organization here in Delaware, by the way, rehabilitation specialists, medical assistants. All of these people get involved in the routine care of seizures, and all of this information is just quite distributed. There's also, we have sort of routine care, but also specialized care for diagnostic and treatment services for patients with a drug-resistant epilepsy. So what does that really look like to the patient? So I have here before 1974, right? So really what happened is a guy named Fritz Dreyfuss in 1974 at University of Virginia looked at this picture and said, oh my gosh, all of these people are contributing to the patient's care, and this is impairing our ability to gather information about the patient. Let's change this. So after Fritz Dreyfuss, a more modern approach became this, that you actually have all of those specialists interacting with the epilepsy center and the epilepsy center interacting with the patient. Since the epilepsy centers started in 1974, there actually are now 233 centers. They're divided up into level 3 or level 4 centers. The level 4 centers are capable of doing invasive intracranial monitoring. The level 3 centers are actually not capable of doing that kind of monitoring, but do the other things that epilepsy centers do. This is recognized by national organizations as being incredibly useful. So, for example, the U.S. News and World Report puts a level 4 accreditation as a component of its national ranking on hospitals with top epilepsy, neurology, or neurosurgical services. Here at Christiana, I was actually hired to start an epilepsy center. Our first goal, hopefully in October, will actually be to apply for epilepsy center status as a level 3 center, not doing intracranial monitoring yet, but doing most everything else. The most important component of an epilepsy center does turn out to be this epilepsy monitoring unit. That's the place that you saw that woman in earlier. That's sort of the crown jewel of an epilepsy center. So what is that? Well, here, about month and a half ago, we actually opened our first monitoring unit in Delaware. It's a 2-bed epilepsy monitoring unit with specialized personnel to take care of patients. And what do you actually need an epilepsy center for? You actually need it to evaluate the seizures, to diagnose them, and then to treat unprovoked seizures based on the information that we get out of that epilepsy monitoring unit stay. And I'll sort of point out these 3 things. It turns out, like, why is really this is 1974 when this came about? What happened? How come there are more than 200 centers? How did this grow like wildfire all over the place? And it was really interesting in that it turns out that the continuous video plus the EEG recording plus the nurse doing ictal testing or testing the patient during the seizure turns out to have an incredible synergy. And those 3 things together created an entirely new test that we call epilepsy monitoring. If someone is going to be admitted to the epilepsy monitoring unit, there are a few different reasons why they might be admitted. One is for possible non-epileptic seizures. We'll talk a little bit about that later. One is for possible misclassification. So I showed you on an EEG that seizures were starting on one spot in the brain, and then another EEG where seizures were starting over the whole brain all at once. It turns out with the medications that we have, that those are 2 completely different categories of disease, and actually we have 2 different kinds of medication that we use to treat those different categories. So we might just be treating the wrong category of disease, and if that's true, it'd be great to figure that out. The only place to do that would be an epilepsy monitoring unit. Also, we actually have a capability using epilepsy monitoring to do some pre-surgical evaluation. That actually did not start with epilepsy monitoring, but it sort of moved to be a prerequisite for that now. Epilepsy surgery in the United States really started in about 1930. The NAC actually gives some guidelines about when a patient is supposed to be admitted to the epilepsy monitoring unit. And it turns out that it's pretty simple. Actually, if anyone has had treatment that's failed them for about a year, they're supposed to be admitted to the epilepsy monitoring unit. And during that time, certainly 2 anticonvulsants should have been tried for that patient, but typically at least 3 during that period of time would be tried. When we tried to build an epilepsy monitoring unit here at Christiana, I was actually a little surprised. I have to say, you heard from my bio, I did all my training at Penn. There was an epilepsy monitoring unit there for more than 40 years. And I don't know if you guys have heard the expression, but it's sort of been born on third base and thought I hit a triple, right? So I came here to say, we'll just start the whole thing all at once. And it turns out that there are a lot of people that are involved in starting an epilepsy monitoring unit. The primary one actually turns out to be something called a neuroscience service line, at least here at Christiana. The neuroscience service line is an organizing principle, essentially, about how to treat certain categories of disease. And they're the ones who actually decided that we should have an epilepsy center here at Christiana. But also nursing is involved, IT, equipment purchasing, got to get pharmacy involved, find the right physicians to attend, PAs, NPs, clinical engineering, EEG techs, monitoring techs, and other sort of new technology, which we'll talk about as well. So let me show you another video. It's a bit longer. This woman pushes a button. That's the warning sheet where you give patients a button to tell the nurses when they think they're going to have a seizure. Nurse comes to examine the patient. This is the typical ictal testing. So that event looked a little bit different from the previous one, obviously. There were a couple things that were a little unusual about that. I don't know if you all noticed, but the seizure actually got a lot worse when the cushion actually fell on her. So that actually turned out to be something called a non-epileptic seizure. So actually it turns out to be pretty common that people have seizures that are really psychological events. And you can have certain things like what we saw there, like eye closure, pelvic thrusting, sort of prolonged duration that keeps going for a long time. That's sort of starting and stopping and starting again. And the sort of suggestibility of it, right? The seizure got a lot worse when the cushion fell on her. There was something that happened that suddenly she said that should set it off. The patients typically are unresponsive during the ictal exam. So it turns out that if a patient has a seizure in which they do not lose awareness, maybe just a twitching of an arm, for example, or a feeling of deja vu only, the EEG only picks that up about 20 or 30% of the time. So the EEG actually is not that helpful for what we call focal aware seizures. But if someone is unaware, that means there's enough brain that's actually being affected by the seizure that shows up on EEG more than 95% of the time. So that nursing exam showing the patient was not responsive to his examination raises the yield of that EEG from a sensitivity of 30% to a sensitivity of 95%. And in fact, for the EEG that was running during that seizure, the EEG was totally normal. So that was actually what we call a non-epileptic seizure. I said, most of these events do turn out to be psychological if they're non-epileptic seizures. We call them psychogenic. And it turns out that there's something called a conversion disorder rather than conversion disorder. And this is a conversion of psychic pain into a physical manifestation. So this is a little confusing to me until my son, when he was 5, he had a sort of a manifestation. He had a sort of conversion, and we have these very simple conversions when we're little and more sophisticated conversions when we're older. But he actually said that he was homesick, and that's why his stomach was hurting him, right? So it's a physical manifestation of some sort of psychic pain that he was having. But also there are other psychological events that can look like epileptic seizures. For example, panic attacks, intermittent explosive disorder, breath holding spells. And I put malingering on there. That's considered a psychiatric disorder. Malingering means that I'm trying to have this, to manipulate everyone around me, right? Turns out to comprise less than 5% of all the non-epileptic seizures. And so if you're thinking that someone who's having one of these spells, if you know anyone who has them, or if you're thinking that person is doing it on purpose in order to get something, there's a 95% chance you're completely wrong. Okay? So these are not actually voluntary events. Now, there are other events which are also non-epileptic, in other words, not epileptic seizures, but are actually caused by other causes. So the number one mimic actually turns out to be syncope or fainting spell, usually caused by cardiac arrhythmia, such as vasovagal syncope or dysautonomic. There can be other metabolic problems like low blood sugar, which can look like an epileptic seizure. actually migraines, when they're really, really bad, migraines can look like epileptic seizures. Other problems you might have heard about, like narcolepsy, movement disorders, and even transient ischemic attacks, which is actually a kind of stroke. Epilepsy monitoring, again, in the older patient, actually does turn out to be pretty helpful, but it's interesting. Now, 76% of patients will have epileptiform discharges, or those abnormal EEG findings in epilepsy monitoring. But actually, 26% of patients with non-epileptic events had epileptiform discharges as well, looked like seizures on the EEG. So it turns out another example of patients over the age of 60 having some false positives on the biomarkers that we have, confusing things again. In this case, also about the non-epileptic seizures that were found, half of them were psychogenic or psychological, but half of them were something else, like transient ischemic attack or cardiac arrhythmia. So it's a very important population to think about studying and epilepsy monitoring in it. How good is an epilepsy monitoring unit for diagnosing non-epileptic seizures? It turns so there was a study. There's a study in the American Journal of Medical Quality. So these are sort of journals aimed at asking the question: is it a good idea to pay for an epilepsy monitoring unit to stay? They looked at 213 epilepsy monitoring admissions. These are people who are actually being admitted not for what we call differential diagnosis. In other words, not admission to decide if the spell is a epileptic seizure or non-epileptic seizure, but instead, the admitting physician was 100% convinced that these patients had epileptic seizures, and it was just trying to figure out where the seizures were coming from so that they could do a surgery and figure out what part of the brain to cut out. Well, it turned out in that setting, 21% only had non-epileptic seizures. So the physician was completely wrong, even though they were absolutely confident. 21%, they were actually treated for an average of 9 years with anticonvulsants for something that they were being mistreated for. Half of them were actually treated with 3 or more anticonvulsants simultaneously. And so the epilepsy monitoring unit yielded a definitive diagnosis in 88% of the patients. And so the EMU for these non-epileptic seizures does turn out to be the gold standard test now for diagnosis. If you look at a general neurology clinic, which is essentially what we've had here in Delaware because we haven't had an epilepsy monitoring unit, somewhere between 10 and 45% of all the patients that we're treating for drug-resistant epilepsy don't have epilepsy at all. They have these non-epileptic seizures, and most of them psychological. I think it's important that we point out, actually, that first line there of data. It does turn out that this happens to women much, much more commonly than it happens to men. This is actually pretty much a women's disease. The psychiatric mechanism can be conversion or dissociation. It does turn out there are enough women that have this that you can actually do some studies with them. There aren't a lot of men you could do these studies with, so you don't have a lot of data. But there's a common association with physical, emotional, or sexual abuse in women. And I've been, doing this for, like I said, over a decade. And I have to say that I think about this somewhat as essentially a symptom of something that's like post-traumatic stress disorder. The diagnosis, as you can imagine, can be pretty complicated. As I described, there can be some issues with trying to differentiate non-epileptic seizures from epileptic seizures. For example, when people have seizures that come from the frontal lobe. So for this group, I think it'd be reasonable to talk about some of the ways in which we try to bring on seizures in the epilepsy monitoring unit. There's some standard techniques you might have heard about, like flashing lights or hyperventilation. does turn out that those techniques are a bit more likely to work in children than they are in adults. So we also use two other techniques. One is that we lower the doses of medication that patients are taking while they're here in the epilepsy monitoring unit to try to bring on the seizures. The other is that we try to sleep deprive patients, and we actually sleep deprive them every other night. One other technique that's actually available here, and at one other place actually in Mayo, Arizona, where they developed that, is that we actually have patients have a safety vest that they can wear that's attached to the ceiling. It's a sort of a rehab developed tool. So if patients fall, that they don't actually fall and hurt themselves. Now you can imagine if you're taking patients who have epileptic seizures and lowering the dose of their medications, the patients might have a more abrupt or more severe seizure than normal. And if we have this safety technique that we can use that actually makes it safe to actually use to, if patients only have seizures when they stand up, then we can actually stand the patients and they can have the seizures here. I find actually that helps not only with the safety of the patients, but it turns out to help a lot with the safety of the staff, right? So if someone is going to fall, and epilepsy in the United States was originally called the falling disease, if someone's going to fall, that nurse is going to go try to help that patient, right? They're not going to stand around and watch the patient go down. And I've actually had staff members at my previous institution get injured from patients having falls and nurses trying to help. So that's actually helping here too, to help save our staff. There's one other thing that people use, which is a little bit controversial. So there's a technique that's suggestion. So I suggested that padding that fell on the patient was a bit of a suggestion. And so people use different kinds of suggestion to try to bring on these seizures. Some people use tuning forks, alcohol pads, very controversially, normal saline injections. They'll call it normazoline. And why is this controversial? Some people say you really should never use suggestion and try to provoke these non-epileptic seizures. Why? Well, it turns out that 23% of people will do that. If you just take it, normal average population, you stress them out by putting them in the hospital for days, you sleep deprive them every other night, and you say, now I'm going to do something and you're going to have an event after this, and 23% of people will do it. So the false positive rate is very high, 23%. Also, people say, we're trying to diagnose non-epileptic seizures in a pretty vulnerable population. Half of these, if these are women, half of these women will have had a history of physical or sexual abuse. And they're already going to be pretty distrustful in any situation that they're in. And now you're going to generate distrust of the medical community. And you're going to hinder all of their future medical care by essentially trying to trick them into having a seizure. While others say, no, you should definitely use suggestion to provoke non-epileptic seizures. Why is that? Well, people say, well, if the most common reason for a failed epilepsy monitoring unit stay, or patients are staying for 3 to 7 days, if the most common reason for failure is lack of event, well, why don't you bring it on so they don't have to do it again? That would help them. You can actually reduce patient exposure over time to anticonvulsants if you make that diagnosis. I'll present a little data why that's important. And also there's reduced costs, right? In an era of costs, actually does turn out to be a much shortened hospital stay if you use suggestion. In general, is that cost effective to diagnose non-epileptic seizures? And one study actually showed that there is a big cost reduction in epilepsy monitoring after epilepsy monitoring if you diagnose non-epileptic seizures. It was an 84% reduction in total seizure-related charges in the 6 months after diagnosis. It was a 97% reduction in emergency department visits. So diagnosis does turn out to be very important for these patients. And what about this drug exposure? Why did I specifically mention that? Well, on one side of things, these medications can be pretty helpful. If these are mostly young women we're talking about, that seizures during pregnancy can be harmful, right? That seizure that you saw, the very first seizure that you saw, that can lead to intracranial hemorrhage, fetal bradycardia, other adverse outcomes like lower IQ in children. There can actually be maternal mortality from that. We don't really have any data on what non-epileptic seizures do to patients. But the flip side of that turns out that there's actually something called teratogenicity. So there's an increased rate of fetal malformations for mothers who are taking these medications during pregnancy. And in fact, even if there's not a major congenital malformation, the kids born to mothers who are taking these medications can actually have an IQ delay compared to mom. So having said that, how bad is that problem? If you're on certain medications, it's really a very bad problem, right? So this is called the North American Pregnancy Registry, and they've defined essentially most of the most commonly used anticonvulsants and asked the question, how bad is the rate of major congenital malformation in women who are for babies born to women who are taking these medications? And they've defined it for each one of the medications. So for some of the medications, it's pretty bad. And for some of the medications, it's almost not that bad at all, but still an increased risk. So let's look at this table a little more closely. This is just a example, and they publish this continuously, and I'll just point out that this is literally data that women are acquiring, paying it forward and acquiring for women. These are women just bootstrapping each other up so they can tell what's going on here. Okay, on the bottom, on the x-axis, is this prevalence of major congenital malformation. And in this case, I will point out that the scale really goes 0 to 10, and then 90% is sort of off to the side, right? It's not even seen. So 90% of all pregnancies of women, even taking the worst possible medications, having seizures, are all totally normal. But a drug like this one, valproate, or other names you might have heard about are Depakote or divaperoxodium. A drug like valproate actually has an almost 9% chance of causing a major congenital malformation, like brain in the wrong place, spinal cord in the wrong place, terrible things, compared to the control groups, which are women not taking these medications, which is sort of about 1.5 or 1.6%. So 1.6% of all pregnancies are going to end in a very abnormal baby. And if you're taking one of the more benign medications like lamotrigine or levetiracetam, the rates are more like 2.1 or 2.2%. So a very small increase over the baseline, but still a serious problem. And if you happen to be treating 100 women who might have a child with the wrong medication, even if it's one of the more benign ones, that actually might be a serious, maybe one of the most serious things that we can do that is going to affect a child and the entire rest of their lives and the rest of the lives of their family as well. So it's incredibly important to get women off these medications if we can. Non-epileptic seizures are a psychiatric disease. So to tell you the truth, sometimes these are hard to treat. And until recently, there were no good proven treatments. And, physicians, other caregivers, if you can't do anything about it, I'm trained to do something about it. If I don't know what to do about it and I feel like I should be helping, but I don't know how, it makes me feel terrible. And maybe I'll say, maybe it's not my fault at all. Maybe it's your fault, right? And I'll reflect that back on the patient. But now there are treatments, and we don't have to sort of have that cognitive dissonance anymore. And 50% actually respond quite well to cognitive behavioral therapy. It's important to recognize that actually epileptic seizures and non-epileptic seizures do coexist. Also, another level of complexity, about 10% of people with epileptic seizures will have non-epileptic seizures and vice versa. We also, when we're thinking about treating these things, we have to be willing to talk about other psychiatric disorders. And then if you're going to ask about that, then what is the prevalence of these mood problems, if you're going to ask? It does turn out that 20% of people with epilepsy will have major depression. 20% will have generalized anxiety disorder, and of course 10% will have non-epileptic seizures. A recent study looking at the prevalence of anxiety just based on a scale and just asking the question, who has symptoms of anxiety essentially, turned out to be up to 40%. So not a diagnosis of generalized anxiety disorder, just symptoms, 40%. So the solution in terms of an epilepsy center solution is some sort of psychologist, advanced practice nurse, or psychiatrist sort of embedded within the neurology department. They can treat anxiety, depression, the non-epileptic seizures, bipolar disorder, insomnia, psychosis. They can provide that cognitive behavioral therapy that you need to treat non-epileptic seizures. On the inpatient side, though, you generally rarely need to use these clinical psychologists unless you're helping to tell patients about their diagnosis. So actually, we're supposed to have a bit of a break. So let's break for a few minutes, and maybe you can reconvene in 5 minutes or so. Thank you. All right, so let's get started as people trickle back in. We can play another video. And it's over. So what you just saw there actually was not a psychogenic event. That was an epileptic seizure. That was a frontal lobe seizure. And you can only tell that because of the EEG that was on his head at the time. So this is a common problem too. What about frontal lobe seizure? That was a frontal lobe seizure. What's the difference between frontal lobe seizures and non-epileptic seizures? There are certainly some clinical signs that you can use to try to tell the difference, but that was pretty difficult to tell the difference between those kinds of events. This kind of problem, when you get into this difficulty with diagnosing patients, we call that, if we say you have epileptic seizures or epilepsy when you don't, it's called overdiagnosis. If we say that you have you do not have epileptic seizures when you do, that's called underdiagnosis. In the UK, actually did a study in 2007. They're a single-payer healthcare system, so they actually really want to know what these things cost them. They estimated in 2007 that it was costing, underdiagnosis or overdiagnosis was costing $700 million per year, which you can imagine in our healthcare system, which is several times bigger. That's billions of dollars a year here. And it was very interesting to me when I actually read this study, because it turns out they did not include the costs of teratogenicity, right? The teratogenicity with abnormal babies, because they said, the cost of raising an intellectually disabled child is actually somewhere between $1.5 and $2.5 million to raise a child age 18. They didn't include that cost of teratogenicity in their estimate because that's actually just too hard to estimate. They couldn't estimate it. So that cost of underdiagnosis and overdiagnosis is probably pretty dramatically underestimated. So if we're going to treat epileptic seizures, there's actually this turns out to be the whole theory. I don't have much else to tell you about this. There's turned out to be the theory of how to treat an epileptic seizure. excitation exceeds inhibition, and you end up with an epileptic seizure. And so we use medications to try to suppress excitation, or we use medications to try to augment inhibition. If you're one of those people that likes pictures, excitatory neurotransmission happens with a neurotransmitter called glutamate. And if you're going to block glutamate secretion that's going to the postsynaptic cell, you might want to block an AMPA receptor with a drug called perampanel. Or you might want to block NMDA receptors with a drug called topiramate. Or you might just want to block the secretion of that glutamate with something that binds to SV2A, a protein, vesicle protein that maybe a drug called levetiracetam might bind to. Or maybe you want to bind to a postsynaptic sodium channel, which will prevent the postsynaptic neuron from firing. Drug like carbamazepine or phenytoin or lamotrigine might help with that. Or maybe you want to augment inhibition, and that would be the main inhibitory neurotransmitter of the brain is GABA, and you might want to augment the transmission of GABA by maybe using an agonist to try to open the GABA-A receptor channel. And in that case, you might want to use a drug like lorazepam or phenobarbital. I will point out that most of our anticonvulsants actually come from something called the anticonvulsant screening program. This guy named Kiffin Penry and a guy named Roger Porter, who started something called the anticonvulsant screening program at the National Institutes of Health. Prior to these two gentlemen, there were a few anticonvulsants: phenobarbital, phenytoin, primidone, carbamazepine, valproate, and ethosuximide. I point this out because Roger Porter actually lives in the area still. They used a screening called one of the screening tests was called the maximal electroshock model. And after Kiffin Penry and Roger Porter, this is the list of anticonvulsants that we have. So this is a tremendous success. The anticonvulsant screening program was the first line item, like one of those earmarks. It was a first line item in the national budget for a laboratory. But this was the result. You guys all paid for it, so you should know. Nonetheless, seizures still have a problem in that about a third of patients are drug resistant. So you can tell actually after one or even two medications are tried, after a first anticonvulsant is tried, only 40% of patients are seizure free. After a second anticonvulsant is tried, 13% of patients are seizure free. Every new anticonvulsant that's used after that, doesn't matter which one it is, pretty much only a 1 to 3% chance of becoming seizure free after that. So that's pretty poor. However, these anticonvulsants do make seizures less severe. They can make seizures less frequent, and in 2/3 of the patients, they make them seizure free. So we do use them. There's a number of things that go into anti-epileptic drug selection for each individual person, but the main one does turn out to be the seizure type. That's the first sort of vector of decision making. Again, in sort of pitfalls. So, and if half of all new onset seizures are going to be age over 60, there are actually some pharmacokinetic changes in people of the age of 60 that we have to pay attention to. No talk in epilepsy is complete these days without a little discussion about marijuana. It actually was listed in the U.S. Pharmacopoeia from 1850 to 1941. And marijuana hashish extracts were actually the first, second, or third most prescribed medications in the U.S. from 1942 to 1890. Then there was Prohibition, and then it came back. Obviously, people think about this as a pretty benign drug because 43% of adults have actually tried marijuana. There's a sort of a theory about how this might work and how this might work to help stop seizures. I will point out that there are some synthetic compounds that you should not confuse with marijuana. One is called K2 or spice. That's not marijuana at all. It's just a psychoactive medication, and it can actually cause seizures. There are some uses of medical marijuana, which the IOM, Institute of Medicine, which is the main sort of advising body to the U.S. government actually does say is very useful. For example, nausea and vomiting in the setting of chemotherapy. They say that's actually a very useful treatment. But the other things that marijuana is used for: neuropathic pain, spasticity, sleep disorders, weight gain, and HIV. And you might have heard of Charlotte's Web, which was a high CBD or cannabidiol extract of this cannabis cultivar. It started to be used in patients who had epilepsy, and so sort of reviewing the data is helpful. A meta-analysis of sort of unselected medical marijuana, in other words, just go get some marijuana and try it. If you put all those little trials together, it turns out to be no efficacy at all against seizures. But there was an NEJM, a New England Journal of Medicine expert opinion, which said that we should try it anyway, and at least the Charlotte's Web, since there's a lot of good evidence anecdotally. And there was other published studies which showed that sort of enriched CBD, or CBDV really, did not really work that well in patients with focal onset seizures. But it actually did seem to work in patients with generalized onset seizures, those seizures that started over the whole brain all at once. It's at least in the kids who have these sort of terrible, devastating, what's called epileptic encephalopathies like Dravet syndrome. An example, one of the studies from Lancet Neurology in patients treated with cannabidiol showed that it was pretty tolerable treatment, but there might have been some problems. There are actually some drug interactions that we weren't quite aware of. It turns out to double the concentration in the bloodstream of one of the commonly used anticonvulsants for this syndrome. So that's a problem. But also 6% went into continuous seizure called status epilepticus. So that's a problem too. And so I guess I'd say that I had a few conclusions about marijuana I wanted to squeeze in here. One is that a sort of unselected artisanal marijuana just has no proven evidence of efficacy against seizures. I know it's sort of approved in some way here in the state, but it doesn't really work. The high CBD content medications do have evidence in these devastating generalized onset childhood epilepsies, but really not in sort of the focal epilepsies or the seizures that start in one spot in the brain. There can be some serious side effects. There can be some drug interactions. A company called GW Pharma is actually applying for approval of the CBD compound soon. So I would definitely not recommend using this now, and we're going to have a lot more information out of the FDA fairly soon about the CBD compound. Once they approve that for the generalized onset seizures for these devastated children, we'll have an idea what are the side effects, what are the drug interactions, and we'll know how to use that. If you actually have patients who are drug resistant, going back to this sort of model where your excitation exceeds inhibition, you get a seizure, if this isn't working, if you've tried all of your medications that you can use, we actually do think about, well, what is causing the seizure, and can we think about stopping that, right? Because the lesions are causing this increased excitation or decrease inhibition. Well, what could we do? So our one disease-modifying therapy that we have is we could actually do surgery and try to cut out that area of the brain. Again, epilepsy monitoring units are mostly used to start surgical referrals. Admission for surgical referral is pretty highly effective. If you were to think about doing a surgery on your brain to try to stop seizures, you might want to ask what the data is. Here's some data for a randomized trial. So these are literally people that are randomized to surgery or just standard medical therapy. Randomized surgery versus just medical treatment. And this is a percentage of patients without a seizure that impaired awareness. So that's 0 to 100 on this axis, and this is months on the bottom. And so you can see the patients who had surgery have a much higher efficacy than the patients who continued on just their medications for the drug-resistant epilepsy patient. Well, okay, you stopped the seizures, but what was my quality of life like? I just had brain surgery. That can't be that good. But it does turn out that the surgical patients, when you do quality of life scales, those surgical patients versus the non-surgical ones, the improvement in quality of life was pretty dramatic. I know it's a little complicated, but improvement is here on 2 different quality of life scales, and the number that improved on medical therapy is here. So much better to actually have surgery if you have drug-resistant epilepsy, both for seizure frequency and for your quality of life. This kind of surgery doesn't actually have to be that invasive anymore. I guess when you're talking about sort of cracking your skull and scooping out part of your brain, that's pretty intimidating to anybody. The patients are generally out of work for a month, sometimes not even really saying that much for a couple of days after surgery is over. But actually now we're starting to have some minimally invasive techniques. So this is something called stereotactic laser ablation. And this catheter right there, this wire, is actually the only thing that's in the patient's brain at all during this surgery. And this is a 7-millimeter burr hole in the skull. And this wire is, while the patient is in the MRI scanner, this wire is threaded into the brain using the MRI scanner to detect heating. The laser is applied to that, and the area of abnormality is actually ablated, and then that wire is pulled out. We actually sometimes can't get enough data from the scalp electrodes that I described at the very beginning, and so an EEG can actually be done using electrodes that are placed directly on the surface of the brain. You can imagine that these are about 7 meter apart, so that's a pretty big exposure of brain there that we have to put that, what we call a grid of electrodes over to detect the seizures. The alternative actually turns out to be much less invasive and much better tolerated, even though it looks a little strange. This technique was developed in France, and there are wires that actually threaded into the skull through those 7-millimeter burr holes, and this can replace this sort of grid of electrodes, and is actually much better tolerated by patients. There are a couple of devices that we consider neuromodulatory. There's a device called a vagus nerve stimulator. There are 2 vagus nerves, one on either side of the neck, that run down into the body. This device actually does intermittent stimulation of the vagus nerve, and literally we still don't know the mechanism of this, but for some reason it seems to work. The FDA approved it and reduces the frequency of seizures, although does not typically make people seizure free. The vagus nerve stimulator runs on its own every 30 seconds out of every 5 minutes it goes on. So it's sort of like a pacemaker. Well, this inaptly named other device is called NeuroPace, and this is actually more of a defibrillator. So this actually dwells in the patient's skull. It detects when a seizure is actually happening, and then it stimulates with electricity that area to try to stop a seizure. And so those are some of the sort of techniques we use to treat patients. I did want to point out that it's sort of a catch-all at the end that I never really talked about how safe something like an epilepsy monitoring unit actually is. And it does turn out that there are adverse events at about 9%. I didn't want to leave you with the impression that this is a completely benign procedure. People can have seizure clusters because we're taking away their seizure medicines. About 58% of those adverse events are seizure clusters. Other problems from anticonvulsants, falls, as we discussed, could be a problem. We do have protocols in place to sort of ameliorate that problem, like using essentially status epilepticus drugs like lorazepam. And here at Christiana, we've copied the Mayo, Arizona model of using this essentially patient sling to help prevent falls. That seems to be working pretty well. We're actually trying to use, there are no useful approved quality measures in epilepsy monitoring units, but we're actually trying to use a couple that were published in Canada to try to see how we're doing in the epilepsy monitoring unit. So I'll just say for the conclusions, I'll say that epilepsy, as we talked about, is a pretty highly morbid disease. The treatment is impeded by the lack of reliable information and diagnosis. And the solution to this, one of the major solutions turned out to be the creation of an epilepsy center. And the crown jewel of that epilepsy center, the epilepsy monitoring unit. In that epilepsy monitoring unit, we can bring in patients who are having spells that we don't know what they are and figure it out and treat them for the right thing. We can bring in patients who are having drug-resistant seizures and change their medications if it turns out that we're treating the wrong kind of seizure. And we can actually recommend patients for epilepsy surgery if it turns out that that's the only recourse that they have. And we can do this in a safe way, using sort of safe protocols and sort of new technologies that help patients remain safe. So thank you very much. And I really appreciate your attention today. All right, so we actually have some time for questions. We have all the way in the back.
You stated that after the age of 60, there's an increased incidence, and also there's medication concerns. So does that, if someone is already diagnosed with epilepsy, how does that 60-year marker affect that person, and what are the concerns around the medication?
So people who've had epilepsy prior to the age of 60, then they typically respond in the same way that other patients below the age of 60 respond. So that's the first thing. The reason that there's a distinction that's made is it turns out that if people acquire epilepsy over the age of 60, the medications are much more effective. So a person over the age of 60 who has new onset seizures, the medications are estimated to be 80 to 85% effective even at low doses. So that's the first difference. But if someone has epilepsy that they've acquired when they're younger and they grow to past age 60, oftentimes people actually have to have their medications adjusted. So there's a problem with lower blood flow through the liver. There's a problem with lower clearance from the kidneys. There are changes in what's called the volume of distribution. So our sort of muscle to bone to fat ratio changes, and the distribution of the medication in our body changes. And now that may change the concentration of the medications in the body. So medications sometimes have to be adjusted by dose, and sometimes they actually just have to be changed completely if the side effects of the medication are too bad. Are there any other questions over here?
Yes, I was wondering, wait till the microphone gets here. Thank you. Sometimes when people are sleeping, your limbs will twitch and stuff like that a little bit. Is that related at all to either of these processes? And the second question was, I've seen people with service animals occasionally that say that their service animal is there to notice if they're going to have an epileptic seizure or something like that. How does that all work, and is that useful? How is that useful to the patient?
The first question is the easiest. So that twitching in the night affects about 1/3 of people, and that's called sleep myoclonus. So it's very, very common. The myoclonic twitches that people have when they have epileptic seizures, if it's abnormal, if it's pathological myoclonus, we can only really figure that out if it happens during the day. So actually, myoclonus is abnormal if it happens during the day. The second part of that was a little controversial, but now it's pretty well settled. So initially, it seemed that dogs might actually be able to detect a seizure before it happened. Well, you can imagine how useful that might be to someone who has one of those seizures where they have no warning at all, and they might go from standing to just stiffening up and falling to the ground and maybe having a skull fracture, to having their dog say, bark, bark, by the way, you're about to have a seizure in a minute, and saying, oh, maybe I should go lay down, right? That would be a huge difference in morbidity. Well, it basically didn't turn out to work that way. So it turns out that the dogs don't really detect seizures anymore. And if you look at the website, for the UCB, the company that actually helps to train these dogs, they don't call them that anymore. Those are seizure assist dogs. I actually haven't seen many of them. One person brought one into the epilepsy monitoring unit, and it's a working dog, so it's able to stay. This guy had a seizure where he would get up and run. He would just run, right? You can imagine that's pretty bad, right? If you run in the middle of the street or something like that, or run out your second-story window, that's pretty bad. So we were trying to help this guy, and so he had a seizure, and he got up, and I couldn't believe it. I'm watching the video. That dog, a big old lab, a big lab, these dogs like to kind of run and knock you down sometimes just for fun. This dog knocked him on his bottom and sat on him. So is that a helpful dog? Oh yeah. Yes, over here.
I just have a quick question. My name's Gina. I'm an elementary school nurse.
Mhm.
And I do have several students that have absence seizures. I have one particular student who was on Zerontin, and she was just under 200 milligrams because she was on the solution. They upped her to the pill, and she developed this unretractable cough.
Oh,
So they took her off and put her back on the previous solution dose that she was on, which was lower. It still has not resolved. And it's been months, and no one can figure that out. Have you ever heard anything like that?
These
I mean, I know
drugs
it's like
are,
gluten,
yeah.
things like that.
So these drugs have. I mean, there are these. Well, I mean, two questions there. Can you be chronically taking a medication and then suddenly develop a side effect from it? I have to say, for the most part, I mean, I've been doing this for a while. Honestly, for the most part, that really doesn't happen. So if you're going to get a side effect from a medication, it pretty much happens within the first few months that you're taking it. But in this case, I'm not sure. I mean, I guess I'd say that, and especially as sort of a you're a caregiver of, of these patients, like what's your responsibility there? I think it's quite reasonable to, see, if a patient like that, who seems to be having some side effects from medication, if they're being seen in an epilepsy center, and that's great. But if they're not, I think that's reasonable to recommend to the parents. They might think about going to DuPont, for example, or Children's Hospital, Pennsylvania. Two great epilepsy centers right in the region. Oh, I don't know.
Hi, my name's Sophia. So I know this procedure where you split the hypothalamus in half. How would that benefit more in patients with epilepsy or without? And what are the benefits?
So there are a number of different procedures that can be done to try to stop epileptic seizures. We generally don't split the hypothalamus in half. It turns out there's something called the corpus callosum, which you might be referring to. The corpus callosum is this very thick white matter bundle, which helps both sides of the brain communicate with each other. There are certain cases in which we actually do try to split the corpus callosum, essentially split the brain into two parts, two brains, really. And that's when patients have something called Lennox-Gastaut syndrome. That's a seizure type. This is an epilepsy syndrome where people acquire some sort of intellectual disability before the age of 3. And the seizure types start before then, typically. And the worst seizure type, they can have all the different seizures that I described, but their worst seizure type turns out to be something called drop attacks. And that is literally when the whole body just goes straight down, just like a sack of potatoes, or something called tonic seizures, in which the arms go up, the head goes down, just for a few seconds like that, and patients can fall too. So those are two kinds of attacks that can cause drops or falls. And it turns out that that procedure you described, literally splitting the communication bundle in half, at least the anterior 2/3, does actually seem to eliminate that seizure type in 80% of patients. So a pretty good procedure, although pretty highly morbid. So you can imagine the brain doesn't necessarily do well when you split it in half like that. And in patients who have very severe intellectual disability, they can actually be, akinetically mute for days, even weeks after a surgery like that. So that means they don't want to move around very much, and they're just fine with that. They don't want to talk, they don't want to do much at all. And you can imagine parents who have elected to have their child have that kind of surgery, that could be pretty horrible after that first day or so. It can be done using the minimally invasive technique. So, in patients who do not have severe intellectual disability, that can be a very useful procedure. And it's used less than it was before, but it's still used. Does that answer your question?
I'm Bryce. I'm a 10th grader at Wilmington Charter, and my question is: do animals experience seizures like us? And if they do similar medicines work on both humans and animals, or are they different?
That is a great question, and it turns out that animals do have seizures. Cats have seizures. Rats have seizures. Mice have seizures. Fish have seizures. Worms have seizures. So anything with a nervous system can have a seizure. It does flip this a little bit on its head in a way, right? So if every animal has seizures, is a seizure really abnormal? It may be that seizures are simply a normal function of having a nervous system, but in the situation where we find ourselves today, a seizure can be pretty highly morbid. The other thing you sort of asked about is if a medicine affects people in a certain way, does it affect animals in the same way? It turns out that if a medicine has ever been tried and shown to be effective in an animal model, well, at least a mouse or a rat for the anticonvulsant screening program, and it has been tried in people, that has always worked. So that's really an amazing result, right? So our nervous systems, the network at least that we use, is very similar among species. One of the most interesting findings, I think, recently was there was a human gene for that Dravet syndrome. I had sort of talked a little bit about that, about using CBD oil to try to treat that. So there's an abnormal gene that those patients have, the sodium channel gene, SCN1A. And Scott Baraban at UCSF took that human gene, put it in a zebrafish, bred the zebrafish, and it turns out the fish, the larvae, the young fish, have epileptic seizures. And they respond to the same medications that humans respond to who have Dravet's, and they are drug resistant to the same drugs that humans are drug resistant to. Very interesting question. And the fact that animal models are so effective and such good models of human epilepsy does give us an enormous leg up in sort of treatment of these diseases.
All right, last question. I don't know where my partner in crime is, but.
Hi, my name is Caroline. I'm a veterinarian. Do you use potassium bromide for seizures in people?
It's a good question. We really don't use the bromides anymore in people. There are some medications which just have sort of fallen out of use for the most part in humans. The reason why we don't use that in people turns out to be that the risk of rash turns out to be incredibly high. So in humans, it actually turns out the risk of rash is about 40%. So we don't really use that medication anymore, although I certainly have known some patients that are still on those medications from the past.
All right, well, thank you, Dr. Pollard. Can I have one more round of applause?
No.